Good morning, everyone. Thank you, Beth. Thank you, PK, for having me. Thank you, Ray, Liz, and Marichu for teaching me everything I know. I owe it all to them. I'm here today to talk about peripheral anatomy. So PAD, Angiographic Anatomy 101. I have no relevant financial relationships. All right, so objectives for today, obviously we're going to talk about peripheral anatomy, we're going to talk about carotid, aorta, a little bit of renal and iliac, and then the lower extremities, important characteristics for identification, and then clinical presentation. So important question, why is anatomy important? Obviously it helps coordinate care, it helps you to advocate, manage, and educate your patients. But ultimately, the question that you want to ask yourself, and not just in peripheral anatomy, but in all aspects of your professional career, what do you want for yourself from a healthcare provider? And I'm going to answer that for you. It's you want somebody who knows what they're doing, right? You want somebody who knows what they're looking at, that can explain things to you when the doctor's not around. This is where you come in. So anatomy is where we start. So we're going to start from head to toe. We're going to start with the carotid arteries. Obviously, you can see here that there's a common carotid, and then it bifurcates, which you're going to hear me say a lot. So bifurcate, split, fork in the road, okay? So bifurcates into the external and internal carotid. The internal carotid is what we're most concerned about in the lab, and we'll go over why that is. But before we get into that, let's talk briefly about the aortic arch types. So this is where the carotids come off of. So you have your aortic arch. Where's my mouse here? Okay, aortic arch, and then you have this line, this line that you kind of make up in your head, but Liz taught me to kind of put your arm like this, and you want to see where the innominate vein, which gives way to the right subclavian, and then the right carotid, and then you have your left carotid and your left subclavian here. So the purpose of doing this before we get angiograms of the carotids is to see where the takeoffs are. So we need to know what kind of catheters, what angulation we're dealing with, and it's also important to know that this is a factor that we take into consideration, and also to know where the carotids come from. All right, let's get back to the carotids. So internal carotid artery is what we care most about in the lab because it supplies the brain. So if you have ischemic or embolic events, it's happening in the internal carotid. So when we think about the internal carotid, we want to look first at the common, and we get to the bifurcation here, and you have this bulbar characteristic, which is a way to identify the internal carotid. It also, you can see, goes straight up into the brain. There's no major branches coming off. The external carotid, on the other hand, supplies the cranial structures of the head and neck, so a little less of a consequence when there is something going on in the external. We don't intervene on that. It's just important to note, because if the internal carotid is occluded, then the external carotid could be giving collaterals and helping to feed the area of the brain where the internal is no longer. So other things to know is that significant stenosis is greater than 70%. Again, we're talking about the internal carotid, so we're only going to intervene on the internal. The stenosis has to be greater than 70%, and if the internal carotid is 100% stenosed, we do not intervene. Okay, so how do these patients present? So obviously you can see here, we have our internal carotid with a very significant stenosis. This patient may be asymptomatic. They might be dizzy or have loss of balance. They might have a syncopal episode or multiple syncopal episodes. But the symptoms that we're really concerned about is if the patient had a stroke or TIA. That's going to be an indication for intervention. So greater than 70% stenosis, but not 100% included, and they had a stroke or TIA. That's the patients that we're concerned about. Okay, so we just went over the aorta and where the carotids come from. I'm not going to get too much into the entire aorta, but as you can see, it's a very large artery. It's the largest one that we have, and it gives way to all the other, well, most other major arteries that we have. So I want to just focus your attention on the abdominal aorta part. If you look at the proximal aorta, you can see that there's two branches coming off right here. Those are our renal arteries, which we will talk more about. So I just want you to know where they are. And then if you follow it all the way down, you're going to see another bifurcation here, and that's where the aorta becomes the common iliacs, right and left, and we'll get into that as well. We're going to skip that for time. Okay, so renal arteries. So again, the renal arteries arise from the proximal portion of the abdominal aorta around the L1, L2. The right renal artery sits slightly lower than the left renal artery, and that's because it's being displaced by the liver, so that's a common thing that you see. And then the left renal is a little bit longer. So the renal arteries split into the anterior and posterior arteries and then further branch, but we're concerned about the main ones coming right off the aorta. So here you can see significant renal stenosis that has been ballooned and stented. So how do these patients present? Classic sign is a patient with refractory hypertension. So multiple antihypertensive drugs still can't reach their target goal for blood pressure. Elevated renal function tests, abdominal bruit, which I think Dr. Singh spoke about. That's a very clear diagnostic thing to do for renal stenosis. But also acute renal failure, which is usually precipitated by ACE inhibitors. And without getting too much into the pharmacokinetics, the ACE inhibitors inadvertently dilate the efferent arterial dilation, which further decreases the glomerular filtration rate, which normally in renal patients is a good thing. But when people have fixed stenosis, it actually decreases their perfusion too much, and you can present with acute renal failure when initiating ACE inhibitors. It's mostly with bilateral renal stenosis, so it is a contraindication for those patients. Okay, so making our way down, we were at the abdominal aorta, and at the end, it bifurcates to the common iliac arteries, and then that again bifurcates into the internal and external iliac arteries. So they supply the pelvic region and the legs. We have the external iliac artery, which is more lateral, and the internal iliac artery, which is more medial. So again, you want to identify the bifurcations. Where is it bifurcating initially? That's your common. And then when that common bifurcates, you have your internal and your external. The external will become the common femoral artery, which is our access point for most peripheral cases. So here's a nice imaging of a right common iliac artery stenosis. This patient may have presented with pain or claudication in the lower back, hips, or buttocks. They could have numbness or cramping. Another thing to note that internal iliac arteries, the patients may have complaints of erectile dysfunction. We do not intervene on internal iliac arteries. It's just something to note. But if you focus your attention on the left common, you can see when it bifurcates again, you have a nicer image of the internal and then the external iliacs. So I just want to talk briefly about the common femoral artery because it's one of the arteries that we see the most in the lab, right? If we're doing coronaries, renals, carotids, peripheral, the legs, we're going to see this common femoral artery. So what this slide is showing is the point of optimal access, which allows for safe manual compression and increases the likelihood of to use vascular closure devices, which is good for the patient, good for the fellow, good for the NP. If the access point is too low, meaning that we are below the mid-femoral head and into the bifurcation of the SFA and profunda, which we'll talk more about, then we have an increased risk of pseudoaneurysm, AV fistulas, and compartment syndrome, especially if we're accessing the profunda. If we're too high, meaning we're above this mid-femoral head region and approaching the inferior epigastric, we have a very increased risk for retroperitoneal bleed. So just some points of interest to know. And while we're on the topic, I know you think I'm crazy for putting this in, but I had to. I want to talk briefly about the kidney transplant recipients and femoral access. So a transplanted renal artery, a transplanted kidney is anastomosed, the artery and the vein, to the either the right or left iliac vein and artery. So it might be not something that we think about often, and maybe even a little counterintuitive, but it would be best practice to identify the laterality of the patient's transplanted kidney prior to femoral access, because as you can see, the transplanted kidney is just above the femoral access site, and we can risk the integrity and cause damage to the graft, which we can all agree took a lot of work to get. So please take this into consideration, and please advocate for contralateral access when available. Okay, so moving on down to the leg, we talked about the common femoral artery, and that bifurcates again into the profunda, which is this branch here, and then the SFA, which then eventually creates the popliteal, and then once we get below the knee, we have our trifurcation AT, peroneal, and PT. So above the knee, we'll talk one more time about this bifurcation. So right here around 1, we have our common femoral artery, which then bifurcates to the profunda or deep femoral artery. We don't want to touch it. We don't intervene. We don't want to get access there, okay? The other area is the SFA, or superficial artery, which is a little bit of a misnomer. It's not that superficial. It's just in relation to the deep femoral artery. The SFA runs down the length of the thigh. There's no significant branches. And it might sound a little funny, but this is kind of how I started learning. I always looked for that one big bone, and I knew that I was in the thigh, the femur, and I should see a nice long artery there. That would be my SFA. When you see the knee joint, you're at the popliteal. So the popliteal is a continuation of the SFA, and that will eventually become the ATPT and perineal. So you're looking for that tibiofemoral joint to identify your popliteal. Okay, so these were 2 pictures that I put together, so sorry if it looks a little funny. So this is below the knee, what we normally call a 3-vessel runoff. Again, there's always variance, but this is what we look for below the knee. So once we get past the popliteal, you'll see this first branch that takes off, a little bit of a show off, if you will, the anterior tibial artery. That will run down on imaging the lateral portion of the image and eventually wrap around and form the DP. So when we palpate the DP, we're actually palpating the continuation of the anterior tibial. Next, after that takes off, you have a little portion here called the TP trunk, which we do here often, which can be intervened on. And then after that, you have your perineal, which comes down nicely down the center and dissipates around the ankle. So we don't really palpate that in the foot unless it's giving collaterals. And then we have the posterior tibial, so on imaging, it'll be more medial, and that's gonna run straight down and wrap around the ankle, and we all know that when we are assessing pulses, we assess the DP, which is again the extension of the anterior tibial, and then around the ankle is the PT. So how do these patients present? They could have tight, hairless skin, which doesn't sound so bad, but in legs, it's a bad thing. Okay. The 6 Ps, which we all know from school, we talked about claudication in the prior speeches, rest pain, which would be more significant, abnormal diagnostics. We could have diminished or absent peripheral pulses. Not necessarily a direct correlation, but definitely an indication that something could be going on. And then ulcerations, arterial ulcerations would definitely be a much more serious thing. And you'll see those on the ends of toes, tops of feet, lateral ankle, and then have a punched out appearance, so on and so forth. For sake of time, I was just going to see if you guys could tell me what arteries these are, but we'll just keep it moving. All right. So, in conclusion, I hope now you can identify clinical presentations of associated PAD, identify landmarks and characteristics, and ultimately identify peripheral anatomy a little bit more confidently now. What do you think? Yeah? Okay. Thank you.